The most challenging step in intumescent cataracts would be in achieving a continuous curvilinear capsular Rhexis. The intumescent fluid must be evacuated before the initiation of the Rhexis to prevent the risk of radialization. Here I am entering the anterior chamber with a 26 gauge needle and puncturing the center of the anterior capsule and aspirating out the fluid. But even after this step, there is still some fluid present in the periphery of the lens capsule. So at this point, I enter with the utrata forceps and I begin to initiate a smaller sized capsular Rhexis, aiming for a diameter of about 3 millimeters. This capsular bag is still quite pressurized, so try to maintain a centripetal force while creating this capsular Rhexis to prevent the risk of radialization. So now that we have a small 2.5 to 3 millimeter size capsular Rhexis, we can now enter the anterior chamber with an IA probe and decompress all those fluidic clefts present under the anterior capsule and adequately decompress the capsular bag. Gently nudging the nucleus back and forth will release all those cortical clefts stuck between the anterior capsule and the lens substance. Now we can make a small nick on the anterior capsule in the place which is most ergonomically comfortable for us to start the enlargement of the capsular Rhexis. Now that the capsular bag is adequately decompressed, you will notice that the flap does not misbehave anymore, and it is quite easy to create a capsular Rhexis of our desired size. We are now ready to begin with phacoemulsification. This being a hard nucleus, use a high power, high vacuum setting. Bury straight into the nuclear core, lift up the whole complex, pierce with the chopper, bring both the instruments together, move them apart, and we have two halves. Now use the same maneuver again to create multiple smaller and smaller fragments of the nucleus to safely bring them out of the capsular bag and emulsify them in the iris plane. The parameters for this case are ultrasonic energy at 50%, vacuum at 500 millimeters of mercury with a flow rate of 36 ml per minute. Now in hard cataracts such as this, one must exert patience and ensure that the nuclear pieces are completely separated before bringing them out of the capsular bag for emulsification. Let me show you what I mean here. Now I bury straight into the nuclear core, hold with high vacuum, and I chop. But the piece doesn't completely separate at the base. So I enter deeper and deeper with the chopper and ensure complete separation before bringing the piece out of the capsular bag. Once again, 1, 2, 3. There we go. Complete separation, and now we can emulsify it. Moving to the end of the case now with IOL successfully in the capsular bag, well centered, and the patient now has a good outcome. Thank you for watching.